Let's jump into it, y'all. About 10 years ago, maybe a little more than that, I was just reflecting on a transition in my career from what I had done early in life, which was construction. And for a short term, in between kind of changes in my personal life and really looking at how I could financially take care of three kids that I had primary custody of. I went and worked in refineries, and I know one of my good friends that's on and a recent student that's online with us is going to speak very near and dear to his heart. Uh, when I ended up in the refineries, I got a quick look at the culture of safety and how off I was on that culture of safety. I'll give you a quick story. I was digging a trench with some guys, kind of the first week of working in that refinery, and I was the type that didn't want to wear gloves or a hard hat or, wanted to take off my shirt, stuff like that. And I wasn't wearing gloves. And one of the guys, he was a big cholo. He was a big gangster guy, right? And he was like, "Oh, he took out this blue card." He's like, "I got my blue card for the day." And I was like, "What the hell are you talking about?" He was like, "I'm writing this up as a blue card." Basically, he was telling on me. And we kind of got into, a verbal argument that almost turned physical because that was my mentality at the time, was like he was telling on me. And truly, I was in the mindset of compliance. If somebody was watching me, that like our friend who's online that was a health safety inspector, if somebody was watching me, I would have been wearing my gloves. But nobody was watching me. I don't need to wear my gloves, right? Yeah, yeah, the famous blue card, Johnny. So if somebody was watching me, I would be compliant. But as far as doing what was right all the time, that wasn't me. And that quickly opened my eyes from this guy who I would have never thought would tell on me, to like he's actually trying to help me stay safe. It was the culture of the refinery that everybody would write these blue cards daily. They would make observations on each other. They would write up these observations. They were non-punitive. They weren't to get me in trouble. They were just to report the incidents and then talk about it among the whole refinery, not by name, but by incident or by the infraction on safety. Safety is so important, guys. When it comes to healthcare, I just want to pose the question now. Are you in the mindset of compliance, or are you in the mindset of culture? Uh, the goal of today's first presentation is to really help you assess that in yourself, assess that in your teams, and hopefully, if it is the mindset of compliance, that you move over to culture. We've all been in a survey, or for those of us who have not, somebody coming into your facility watching you. Second question for you: do you do things different when you're being watched? Next slide, Melissa. So, what's the impact of that culture of compliance, or doing things only when people are watching, versus culture? The World Healthcare Organization reports that 1 in 10 patients experience harm in developed healthcare systems, 250,000 deaths a year attributed to medical error per Johns Hopkins. Culture is a hidden engine. It truly is an engine. And without that engine, that culture of safety, which also translate to quality, we are guaranteed to have these sort of 1 in 10, 250,000 deaths, these sort of incidents. Can we avoid all of those? When we talk about harm developed in healthcare systems, whether they're dialysis centers, nursing homes, hospitals, when we're talking about medication errors, what do you guys think? Can we avoid all of those? Every 1 in 10 of those, every 250 deaths, if they are all errors or developed in healthcare systems? Chime in with that, guys. What do you think? What's the percentage of avoidance we can have there? And while I do that, while you guys are chiming in, let's take an example that a single missed handoff in a intensive care unit can lead to medication errors, falls, missed infections. Uh, uh, all of this can result in what? Patient injury, illness, or death. I see some of you online, you come from the nursing home environment, and I can't help but reflect on falls. I can't help reflect on falls. Uh, a lot of attention goes into falls in that environment. And when we don't pay attention to the preventative measures, the orders, the precautions that need to be taken, the focus on those that are high fall risk, what happens? You know, I think a lot of people think, well, when the state comes in, they look at our falls, and we got a lot of falls and we're under fire. But really that's the smaller of the evils there. Um, I personally have seen patients as a result of falls that have had lesions on the head, subdural hemorrhages, and have died. So we have to be attentive. We have to be beyond compliance. We have to have that culture of prevention. That culture, it's really generative. It's not reactive or proactive. It's generative. Next slide, Melissa. So what is a culture of safety? What is a culture of quality? Leaders and staff have to prioritize safety and quality above competing goals. Question: do you feel like your leaders are committed to safety and quality with the constant pressures of throughput and meeting the schedules of filling beds? And do you feel like the staff are prioritizing safety and quality above all and else? Are they generative? Are they proactive? Are they reactive? Are they pathologic? Chime in on that, guys. Do you feel like your teams you work with, are they holistically committed? Is there open communication? Is there mutual respect? Do you feel like you can speak up? Is there accountability at every level, or just the subordinate level? Is there a willingness to report and learn from mistakes? Like the story I told you about the young man that was writing his blue card on me. He definitely was willing. He wanted to fill out his blue card. Hey, anybody online, what if you were mandated to do some reporting every day, how would that change safety and quality in your clinical environment? Yeah, Kimberly, yeah, absolutely. We need to create an environment where it's safe to report even our own errors, which who's willing to live up to that? Accountability is a core value that we all should have. It goes hand in hand with integrity, right? In contrast to this definition that I just gave of shared commitment, of open communication, mutual respect, accountability, willingness to report, the contrast is that we follow the rules because we have to. We do the right thing, even when no one is watching, is absolutely integrity. So Richard Cabrera is sharing with us that currently experiencing a culture change, transparent communication is key to those transitions. 100% agree. Next slide, Melissa. So what is the current state of healthcare safety? What is the current state of healthcare quality? The Agency on Healthcare Research and Quality had a recent survey, 2023. Only, let's just call it half of the staff out there in the lines feel comfortable reporting mistakes. How do you guys feel about that? Do you feel comfortable reporting mistakes, your own or somebody else's? How do you deal with it? Like, what do you guys do when you see a compromise in safety or quality? What are the top cracks in care regarding safety and quality? Communication breakdowns during shift changes, especially. And there was a short time where I ran a nursing home. Those of you who work in the nursing homes, how important is endorsement on the shift changeover from the first, second, third shift of the day? How important is that endorsement? Are there things being left between the cracks, being left as unsaid on those endorsements? If you're the one endorsing, how thorough are you? Do you go through, I don't know what your patient load looks like, but do you go through your 20, 30 patients to all those med pass and charge nurses? If you're a CNA in the nursing home, are you endorsing to the next CNA on the status of the patient, on when they were turned last, on whether they need to be groomed or not, whether they ate their meals, things like this? Vicky, I'm glad you feel comfortable reporting mistakes, both yours and someone else. No. So you're willing to take personal accountability, but you feel maybe some discomfort in reporting others. I'd love to know why, Vicky. Um, so yeah, those communication breakdowns, hierarchical barriers, junior staff afraid to speak up. Is that the case out there for any of you? It is again, according to this recent survey, hierarchical barriers are absolutely, blockers to safety and quality. Normalization of deviance, shortcuts. Oh God, don't get me started. Who works in dialysis here? Chime in. Who works in dialysis? Who's a dialysis tech, a dialysis nurse? Do you see shortcuts? Do you take shortcuts? How many patients do you have per shift? Do you have enough time to actually get all those patients on, get them off per schedule? And if not, how do you deal with it? Do you shortcut? Do you do it right, make them late? What do you do? Some of you dialysis techs chime in for me. So an example, 2022, a hospital system's near miss reporting dropped 30% after leadership changes. Staff feared retaliation. If you got that leader that makes you afraid or that actually retaliates, what do you do about it? What do you do about it? Do you report it? Who do you report it to? Do you have anonymous reporting lines with your company? Do you have a blue card like system where you can have just reporting mechanism without it being a punitive to where the entire company can deal with it? I got to say that, and Johnny, who you're online with me, I've never seen a culture of compliance like I saw in the refinery environment. It was amazing. And I think that healthcare could learn a lot from the culture that is being practiced and that is being lived in the refineries today. Be in compliance at all times, even when no one is watching. Report to the highest in charge. Great. Next slide, Melissa. So what are the states of culture? And I'll give you a chance to read this over. Pathological, reactive, calculative, or generative. Which one do you and which one does your organization fall in? Is the attitude of your organization that safety is how we work, it's everyone's responsibility, that we're proactively identifying risk, that we have open dialogue, shared accountability from all levels of colleague, whether it be a leader or whether it be a line staff? I hope so. That's a generative culture of safety and quality. That's where we all want to be, generative. So if you're taking notes, I think, take notes on generative. Or let's go all the way to the opposite end, top of the slide. Is it pathological? Accident happens, just don't get caught. When they do happen, you blame others or somebody blames you. There's cover-ups. There's minimal reporting, so there's no opportunity to take the lesson. How important are documents like incident report or adverse patient occurrence? Anybody chime in? Kimberly, I'd love to hear from you on that one. How important are incident reports and adverse occurrence reports? What purpose do they have? Is it to get us in trouble or is it to get us in the better place? Yeah, Vicky, very important because we learn from them, 100%. We only make changes off of data, right? Yeah, Richard, case studies and quality improvement. I mean, I'll use dialysis as an example. We've got decades of data behind us. And if we weren't collecting that data, where would we be today? For those of you who know dialysis, do you remember the days of dialysate colony forming unit being 2,000? Where are we at today? We want like less than 100. Do you remember the days of ultrafiltering patients all the way up to 2 liters per hour? Where are we at today? 10 ml, less than 10 mLs per kilogram per hour. So if we were to do things the way we used to do things, I mean, I say this quite often to my students. If I were to do things the way that I today, the way that I did it when I started dialysis, I'd be fired immediately. Kimberly, so important. It's key and a great starting point in ongoing QAPI process. If you do it right, quality improvement should be continuous, 100%. It doesn't stop. It is generative. You don't just react. You're not just proactive. Let's look at reactive. We fix things when something goes wrong. It's always okay, but when something goes wrong, then crisis will drive the change. It's inconsistent in follow-up. And then calculative. We have lots of rules and checklists. We focus on audits, we focus on paperwork, but not real learning. I think a lot of organizations, that's where they're sitting, is that calculative area. We all have QAPI, we all have continuous quality improvement, we all gather and report data, but are we living it? Are we living in that generative state where we're proactively looking for more? There may not be a problem, but I'm looking for it. Next slide, Melissa. So just a breakdown of the states, the different areas that to reflect on. Leadership. Let's just look at generative for the sake of time. With a generative culture, leadership is not just supportive, but they're also visible. How many of you have a director of nursing, an administrator, a regional operations director that is a keyboard warrior, sitting at home or sitting in some office and never actually come to the floor to see what's going on, never talk with the staff to hear their lens, never talk with the patients or their families? Anybody in that situation? You got a keyboard warrior for your leader? Staff should feel empowered in a generative culture. The reporting culture, it's encouraged and it's valued. Valued meaning that it's going to be heard, it's going to be considered, it's going to be used as a tool. And then the accountability is shared and it's constructive. Yeah, if you're in that situation, it's time to look for a new job. Thanks, Kimberly. So accountability. What do you guys think about productive conflict? So when we talk about leaders and what really matters on the floor, in the ward, in the treatment, in the case management or the care management, how open and what's the response from your leaders, your colleagues, when you give criticism, when you give opportunity for improvement? Is it considered as productive conflict, or is it considered as a smack in the face? Yeah, I like that, Kimberly. Healthy conflict. Without healthy conflict, there'll be no growth. Anybody ever been told like, well, you're just an employee, like, and in my words, like, shut up, just do what you're told? Anybody ever been told that? And I'm going to agree with Kimberly. If that's where you're at, I think it's time to find a place that values healthy and productive conflict, because that's a place where you have the opportunity to flourish and provide the best level of care, safe and quality care. Next slide, Melissa. So thanks for all the feedback, guys. I see a lot of chat coming in here. Nursing home staff, dialysis staff, case management staff. I see one of Kimberly again, been in that position where healthy conflict and productive conflict is not valued. She made a decision to leave. No desire to work with folks like that. Like what's the consequence? Why do you guys do what you do? Chime in on that. Why do you do what you do? Why are you a nurse? Why are you a dialysis technician? Why are you a CNA? I don't know too many people that when I ask that question, say to put money in my pocket. But be honest with me. Let me know. Why do you do that? It's more than a job. It's a calling, it's a profession. You know, when it comes to that job type of language, it's a career. And yeah, to serve people. Thanks, Ruben. Good to see you. Desire to help others. Passion. Thanks, Richard. Good to see you. So, what are the behavioral changes that we need? As I mentioned, as we started the podcast or the webinar, sorry, I got a podcast too, guys. So as we started the webinar, taught thousands of students over the years. And, you know, I'm not blind to what's going on out there, whether it be in the nursing homes, whether it be in the dialysis centers, whether it be in the hospitals. Let's face it, the United States healthcare system is business, right? And sometimes it can be, as a student told me yesterday, a dark looming cloud when you start to think about that. It can be. So what are you going to do? You're going to be the light under that dark looming cloud. You're going to be the light in the darkness, right? Modeling transparency. Modeling transparency. All of you are leaders, whether you're the CEO, COO, admin, director of nursing, a staff nurse, MedPass nurse, charge nurse, whether you're a dialysis technician, whether you're a CNA, whether you're a phlebotomist, you're all leaders. And leaders set example, right? Leaders hold themselves accountable and hold others accountable. They expect accountability. They expect integrity. I've been in the position where, you know, a lot of the people around me are in that culture of compliance versus the culture of safety and quality. And I can honestly say that when I do things different, or when I've seen students or colleagues do things different on that generative level, that people around, it becomes infectious. Not just because they see somebody doing things the right way, but because the patients notice. What do you guys think? Do patients notice when they have somebody that is generatively acting with a culture of safety and quality? And do they start to hold those that don't hold that same level of culture accountable for, you know, for themselves as their own advocates? Yeah, I think so. Yeah, Richard, patients notice everything, good and bad. So what do you want them to notice about you? Do you want them to notice that you're taking the shortcut, that you do things differently when the boss is around or when the state comes in? And go look on the patient groups on social media. Go look at the patients who are speaking up on LinkedIn. They notice, and they're starting to raise their voice. Empowering staff. Yeah, we need to empower staff. We got to use a stop the line protocol where anyone can halt the process if safety is a risk. There's a very strong nurse leader in the nephrology space. Her name's Glenda Payne. I'm name dropping Glenda Payne. And she's talked a lot about safety and the culture of safety over the years, both her and Judith Carey from CMS. When you feel like you have that hierarchical barrier where you're scared to tell your boss that something's wrong, what's the key word, everybody? What's the word that absolutely stops any healthcare practitioner in their tracks? Or what's the term that you can use? What can you say to make them pay attention? Anybody? What's the trigger for stop the line? Audit. How about I have a concern for safety? What happens when you say I have a concern for safety, or I'm concerned about the patient's safety? What does that do to any healthcare practitioner? Does it make them stop and think? Does it make them stop and reflect on, you know, assess the environment? Yeah, pause immediately, 100%. Nobody is gonna, and if they are, they're definitely in the wrong place. I hope nobody works with anybody that would continue on when there's a concern for safety. It's time to stop, pause, reflect, assess, environment, scenario, patient, medication, all of that. We need to encourage reporting. Anonymous reporting system seems to work best. With anonymous reporting systems, Johnny, what do the refineries do with that anonymous reporting system when these thousands of blue cards come in a day from all the workers in the refineries? What happens to those blue cards? Do you have safety huddles in your facility? Do you stop and reflect on the things that were reported if you have this type of system? And that's what happens in the refineries. I was amazed by the amount of time, energy, and even reward that came from these anonymous reporting systems. Let me tell you a way to encourage reporting, incentivize it. Incentivize it. So I worked in this refineries. Every morning there was a health or a safety huddle. They would look at the blue cards from the days before, and they would pull one of the blue cards and they would give somebody, a movie ticket or a dinner for, some local restaurant. Nothing like, 5-star steak, but something to say, not only do we encourage, but we value reporting, right? Recognition, as I said. Good catch. Good catch. A pat on the back, a recognition before peers, public acknowledgement of the reporting that, hey, this person really cares and has the culture that is going to keep people safe. Whether it be, is your safety important as a healthcare practitioner? Wouldn't you hope that your colleagues are reporting things that would keep you safe? Why is it different with patients, right? So recognition is an absolute great way to, and incentivization to encourage that reporting, to create the behaviors that are going to keep patients and workers safe. Next slide, please. So system level changes. Yes, leadership needs to jump on. We need safety rounds. That means they got to get out of their chairs. And guys, if you're a leader, I'm not accusing you of sitting in your chairs all day. I asked the question earlier of do you have that sort of leader? But I'd ask you the same thing. Are you that leader that sits behind a dashboard all day, that looks at the cameras all day, and never actually gets into the trenches? Safety rounds are important. Regular staff forums. If you don't know what your staff are seeing, you're blind, right? Or if your leader doesn't know what you're seeing, they're blind. Visible executive presence in clinical areas. How do leaders handle unseen safety issues, such as bad bed sores from lack of rotation? Yeah, absolutely. How would they even know? From a dashboard, it's a reporting metric. From the trenches, it's a problem-solving exercise. One of our attendees says they had to report an MD once who endangered a patient's life, did not follow his orders. She did not follow his orders and did report it. You can catch even the doc, right? Something going wrong, inappropriate care. You can catch this as well. And again, stop the line. My organization did that. They gave us dinner and kudos in our community's newspaper, and I had saved the patient's life. Man, that's a great story, Kimberly, and a great example. Great leadership on your part. Integrated training. Onboarding includes safety culture modules, and meaning teach people how to practice that culture. It's not a natural state. It takes practice. It takes forced behavior in some cases, meaning like you every day you have to do some sort of reporting. Again, if it's anonymous, if it's non-punitive, non-retaliatory, even better, because then people will feel very good about doing it because it's all for the good. Near misses are also important, 100%, Johnny. Near misses are as with the story that Kimberly mentioned, life-saving in many cases. Ongoing simulation training, practice the scenarios, data-driven important. So yes, we all love data, hopefully. We know that data and the aggregation of data, chopping it up. So, there is time to sit behind a dashboard and assess all of this data. You have the QAPI meetings, you have the reporting metrics to CMS, into the state. And we all remember COVID, right? And, the daily updates on which county had higher incidence or higher infection rates, the death rates, these sort of things, the vaccination rates even, right? Aligning policy with reality, regular review of policies with frontline input, and simplification of complex processes. I gotta say, and argue with me if you feel the need. I see so many staff out there who've never seen the policy. I see so many staff out there who get the what do you call this? Like the compliance type of training within their first 30 days, but never sat down or never had a forced encounter with policy and procedure. Richard, thanks. Don't just go through the motions at QAPI. Make sure to dig deep and truly evaluate each scenario. 100. Next slide, Melissa. So let's look at a scenario. Medication error occurs. If a staff reports it without fear, leadership will respond by analyzing system gaps and not blaming individuals. Is that always the case with a medication error? I hope so. When it comes to a practice or to maybe holding a leader accountable, like in the case that you brought up, Kimberly, how did the leader respond? I'm curious. How did the doctor respond? Obviously, the healthcare organization responded well and valued the input. I'm not sure how that MD responded, right? Did they blame anybody besides themselves? With a non-retaliatory, with anonymous systems, we have the best chance at making improvements. So a key point, system changes like easy reporting tools enable behavioral shifts like openness, encouragement, behavioral changes like staff speaking up to drive systems to improvement. I love it. I didn't care how the physician responded. I had still have no respect for him. Obviously, this was perhaps beyond a mistake and maybe a, not the right person taking care of a patient. Next slide, Melissa. So resistance to change. Who says it? Who says this? We've always done it that way. In some cases, and nothing happened. Right? We've always done that way, and nothing happened. So in 2000, I entered my first professional experience as a dialysis technician, and I was given a preceptor. And by the way, he's still my friend today, but as a student, I almost slapped him in his face for something he said to me. And by the way, if you know me, that's a real almost. So we had been working on the floor, and it was his turn to check the water, do the water logging in a dialysis treatment room. And for those of you who know the dialysis water treatment room, there are several devices, gauges, tanks, exchangers, heaters, things like this, that you go through this checklist and you document everything as it is today. So Monday through Saturday, there's a log. And you'll see this. A lot of people who do those checks are actually on the floor as well. They have to leave their patients, go to the water room, do the check. So they can be in a hurry sometimes. Throughput's important, right? Schedule, respecting people's appointment times, it's important, but not more important than safety and quality. So we went in the water room, and he's going to show me how to do the water logging. And he gives me the log and he says, listen carefully. He says, just write down what was written on the last day. And I was like, wait, what? Now I had been doing dialysis at home for a family member for years before that, doing one check, per treatment, not doing a whole water log, but a few checks that were relative to safety at home. And I knew that wasn't right. And I was like, bro, that's not how you do it. Like I got to go through each one of these and I got to document accurately. And he said to me, nothing's going to happen. Nothing ever happens. So maybe there are those sort of situations that you do different sort of checks and nothing ever changes. Maybe there are those sort of situations. I mean, especially dialysis is a very routine procedure. Quite often, prescriptions stay the same for long periods of time. Quite often, water system documentation is fairly consistent. But what about the day when something changes? What about the day when you've got a busted tank, when you've got a high chlorine level, when you've got water hardness that is through the roof? What happens to patients? There's a major compromise in their safety. So we've always done it that way. Pencil whipping is a horrible mentality. What state of safety and culture is that? Is it generative or is it pathologic? We've always done it that way. Is that generative or pathologic? Does it keep patients safe or is it a disease within your organization? Complacency. High reliability organizations guard against drift by regular training and audits. Education is so important, right? That's why we're here today, continuing education. But your clinic should also be doing regular and comprehensive and well thought out training that is relative to what you do every single day. Policy and procedure should be reinforced on the regular. Audits and expectations of performance should be done regularly, documented, and plans of correction should be not just when the state comes in to your facility. Internal statement of deficiency, internal plan of correction are a must to have safe and effective care. Leadership turnover, prioritizing onboarding new leaders to the culture, not just operations. They're not just plug and play. They're not just there for a P&L. They're not just there for marketing. They're there to lead. Strategy, use just culture principles. Balance accountability with learning. In other words, again, they're not just there to do the job. They're there to lead. Next slide, Melissa. So measuring progress and sustaining change. Safety culture survey scores, nursing home scores, dialysis facility scores. Facility compare. Anybody heard of that? You can look up your facility. Just go look up facility compare. If you're a dialysis facility, you can go look up dialysis facility compare. If you're a nursing home, you can do the same. If you're a hospice company, you can do the same. I mean, patients should be using this, right? They should be shopping for the place that is actually performing and providing the level of care and the modality that is right for them. Not just because I'm just going to use this term generally, Dr. Joe, let's say, says, this is where I do the rounds. This is where you should go do dialysis. What if I want to do home dialysis, home hemodialysis? What if I want to do peritoneal dialysis? What if I want to keep working in the day and I need dialysis, after 5 p.m.? These facility compares are ways to find the right place, right? When it comes to safety, infection rates, morbidity, mortality rates, all of that's public data, right? Is the data true? Are we reporting? Is everything in there? Do you think every incident is an incident report? That every adverse occurrence is an adverse patient occurrence? As far as the reporting mechanism, I know it's not. And what I mean by I know it's not, a lot of these things are not actually getting reported. Continuous improvement, quarterly safety reviews, root cause analyses, a true system to looking at safety, action and follow-ups, plans of correction, education, accountability. Celebrate wins, share stories of improvement, like in the case that Kimberly shared with us. Near miss, patient's life saved, and complete recognition across the organization. Highlight the team's contributions. This is going to give a satisfied and fulfilled workforce. So guys, thanks for sitting through the rant. Immediate steps. Let's open it up to all of you. If anybody wants to jump on, we got 12 minutes, and then I'll introduce our next speaker. What's one thing you'll do differently after today when it comes to safety and quality, to have that culture, that generative culture that is so needed today? Again, I'm inviting all of you. Anybody want to come on, just put your hand up in the chat, and I'll put you on as a panelist. So I'm opening the floor to discussion at this point. Thank you, everybody. I'm going to call your names if you don't volunteer. Richard, I'm going to open up to you.
Yeah, you know, I think, thank you for including me in the presentation today. I think, you know, there's a lot of good points in there, but I think what the biggest piece for me is you always want to look at the performance of your facilities that, you know, whether you're a patient or whether you're in a staff member.
Yeah.
For me, it's always important to know how you're doing, and really kind of do that self-evaluation when you're a staff member. But when you're a patient, it's more important, I think, even then, because you know, you really want to know how well the facility you're being cared for in is being operated, whether you know, patient or family member. And I always used to look at that, you know, and you'll hear about that in my presentation today about my experience with having to evaluate a facility that you're part of, but also that a facility that your loved one is being cared for in, and really having both sides of that perspective. So I'm going to share that a little bit in my presentation coming up. But yeah, I think that's good advice, and it's good practice to be able to really look in and really evaluate everything from you know, A to Z, and really make sure that quality is there, and that the people that work there are really striving for improvement.
Agreed. I see a comment from Vicky, and I'm trying to pop in a few people as panelists. It looks like camera shy or mic shy today, but I see a comment from Vicky. Vicky, in many cases, RN and staff understand the need for change, but leadership shows hesitancy. Richard, any experience with hesitancy or just absolute resistance from leadership?
Oh, 100%. I mean, I could tell you stories. I mean, there's been times I've been through so many surveys in dialysis clinics over the years, and I can tell you stories where you knew there were specific administrators or managers that were over their head and didn't know how to address concerns or even you know, conditions and things that came up during surveys, where you know, they were worried more about how it was going to reflect on them than it was about how it was going to, you know, about improving the clinic and the quality for the patients that we were caring for. So that hesitancy can come from a selfish place. Sometimes it comes from a place of fear. A lot of times it comes from a place of just feeling inadequate and not knowing what to do. But I think that in any situation, without the right leadership, you're not going to have the right response. And I think sometimes leadership doesn't need to come from above. Sometimes it has to come from the people that are you know, doing the day-to-day grind. And and that's kind of where I used to sit, because you know, in my role, I was kind of, my hands were in everything, because I knew a little bit of everything, a lot of everything, working with water, working with, you know, labs, working with patients as a preceptor, and with the staff. And so, you know, sometimes if it was up to me to step up into that leadership role and try to help navigate through some of that stuff and make sure that our leadership wasn't making bad decisions that were going to reflect poorly on our facility.
Thanks, Richard. I just brought in Johnny Long. Yeah, thanks, Richard. Just brought in Johnny Long, and Johnny, I'd love for you to tell kind of the lens of safety and culture that, you know, prior to being where you're at today, where you get that lens from.
Hi, good morning, everyone. Thank you, Michael. So my background is health and safety in refinery, so it's more of construction based, but it has a lot to do with communication, following procedures. So I agree with Richard. No matter what level you are, if you're gonna preach safety or follow procedure, you have to be able to do it yourself
Mm,
at all levels and take if someone comes up to you and approach you, start with a positive and address the issue and end with a positive. So that way that conversation is not awkward, but you want to be able to have all levels of um, communication, level of communication throughout the organization. So to where you have a culture to one person could address the supervisor or address the nurse without any fear of repercussion. So it's
yeah,
all a learning process, and to set that standard is a good working environment. So
yeah. Hey guys, let me throw a scenario out too, and it's a real life scenario. So, dialysis education services, we've done a lot of things over the years, a lot of consulting for organizations outside of just education, primary education, I should say. And we had a few years contract with an organization that had multiple repeat deficiencies around infection control. So they, in part of their plan of correction, they wrote up that they'll have third-party auditors come in and do, not a Medicare or Department of Public Health audit, but an internal audit from a third party. So we'd go in every quarter and do this. And I'm not sure how your facilities are operating today, but the craziest thing is we'd come in 1 month and we'd work with staff for a week. And, in the beginning of the week, it was like, oh, they're here and we got to do this. They were on that compliance tip of somebody's watching, let's do it different. They were still horrible. We would fix them up, we'd do a bunch of in services. By the end of the week, they were rocking. Then we come in the next quarter and the staff turnover was so bad that they would be a whole new crew. So we'd have to start over again. Anybody in that situation at work where you just can't keep the talent that, you start to build on something, you get quality and safety up, and then it's a whole new crew. It's a new leader. It's a new nurse. It's a new tech, or everybody's new faces. Anybody in that situation online? If so, like, can you chime in and tell us a little bit about it?
Well, Michael, I see it a lot in my role working with skilled nursing facilities.
Yeah.
Skilled nursing facilities probably have some of the highest turnover of all healthcare settings,
Yeah.
and it's something that in my role I work with probably 200 different skilled nursing facilities across the country, and you see the staff change so frequently that it's a
Mhm.
burden. It's a burden on the providers because they have to constantly be educating and constantly be monitoring, and that inconsistency can very easily translate to poor quality of care. And SNFs unfortunately have a poor reputation for quality.
Yeah.
It's one of those stigmas that comes with it.
Yeah.
And it's not fair, but it is an issue. And I think honestly, I think if we could find a way to make that environment a little better, I think there would be a huge improvement in quality of care for that population of patients in a big way. But it's a tough problem to solve.
Agreed.